Against?
Already an interesting discussion, and I can tell Manuel that we in our reproductive unit have a special service against what is called Team Denmark athletes who are thin, who are exercising, exaggerating, also ballet dancers invited. It's not only estrogen, it's a negative calorie intake. So if you don't correct it, you will have no effect from estrogen. That was just a starter. Now I'm happy to, no, I'm not happy, but I have to confront my old friend, John Stott, and argue that gynecologists have no role in the treatment of postmenopausal osteoporosis. Now, obviously, we have an interest because we care about women. We care about women in all age groups. So it would be nice if we were also experts and could manage osteoporosis. Because we are looking after women. And we know that women are more prone to develop fractures compared to men. So we should be able to give advice to handle the situation, but can we? We should be able to do it because there is a causality between estrogen deficiency and bone loss. Indicated on this slide here, two items in the mechanism. You have suppression of stress hormones, of cortisol, and you have a direct impact on the osteoblast via TGF-beta, transforming growth factor beta. So you will decrease bone resorption, increase bone formation at the cellular level if you have sufficient access to estrogen in your skeleton. So if you lack estrogen, you will have an unbalance. It may be irreversible after the menopause between formation and resorption. And behind this unfortunate imbalance is a mechanism involving the rank ligand, which is close to the transforming growth factor. Now the rank ligand will leave osteoblasts and they will bind to osteoclast precursors. They will cause the osteoclast to differentiate. They will be activated. You will have destruction of the bone. But if you have sufficient access to estrogen, the osteoblast will balance the resorption. So in premenopausal women, you will have this balance between resorption and formation. So again, we have a basic interest because we know something about estrogens in this process. And also we know from different guidelines that in order to prevent fractures, we should screen postmenopausal women between the age of 50 and 69, especially those who are predisposed with previous fractures. And it's not so difficult to screen. We can use the DEXA scan based on the whole body, and we have measurements, the T-score, the Z-score. The T-score is what we use, where we compare the BMD in a given woman to the BMD in younger women. And we have some deviations in the T-score that will indicate to us whether there's a normal condition, whether we have a woman with osteopenia, or whether we have a woman with established osteoporosis. It's not so difficult, even gynecologists can find out. Now the next problem is that the BMD or the T-score is not really predictive for fracture risk. In fact, most fractures will occur in women who have not osteoporosis, but osteopenia. So we need to have more background knowledge in order to prevent fractures. It's not just measurement of the T-score, a pity because gynecologists, they like technology. But it is a fact that T-score is not sufficient. You may have fractures that is age-independent based upon other existing factors in the women compared to the T-score. So here you will see that with identical bone density, there is a diversity of incident rates for fractures. Number of risk factors have an impact on the clinical situation with the fracture. So we need to be better. And all gynecologists have a computer on their desk. So they can improve the evaluation from just measuring the BMD or the T-score by applying the FRAX developed based upon Australian population and generated by the WHO. Maybe you're all aware of the FRAX monitoring. It's free on the internet, and you, apart from the BMD, also inform the system about other risk factors, and it will predict on a geographical or national basis the very precise risk for having a fracture and indicating a condition of being osteoporotic or osteopenia to a much higher, well, precise degree compared to just the T-score. So the gynecologists, they are able to do that. I'm sure we are able to do that. And then let's look at the types of fractures that we should be aware of in our clinical practice. There are the primary osteoporosis occurring after the menopause. There is the severe osteoporosis with a low T-score, and there's the tertiary prevention where we have seen a fracture in a given woman or patient. And if we do the risk evaluation in the primary and secondary prevention situation, it's not so difficult. We can also inform about the lifestyle modification and the impact on risk we have in preventing primary and secondary osteoporosis or fractures. We can also administer calcium and D vitamin. It's not difficult. And of course, we can also administer HT and SERMs because we know about these products. But I think John has indicated to us that we are more concerned or more hesitating when it comes to bisphosphonates, strontium, or rank ligands, to the anabolic treatments or to the molecular treatment with the rank ligand. Here we are a bit hesitating. Also, when it comes to the anti-absorptive treatment with PTH, we need some special training or information. So will we have enough ammunition? Will we be able to take proper care of these women in these different categories? Well, calcium and D vitamin, it's easy to administer. We can do no harm. And it seems to work, at least in one Danish study. In a meta-analysis on different trials, it did not seem to be so efficient. So this easy way of preventing may not be good. It's easy for gynecologists, but it may be inadequate for the women. And besides, there are some undesired side effects in relation to the cardiovascular system. So, not too good to offer to women who are predisposed to osteopenia, osteoporosis, and even fracture. But then, of course, we have the hormone. We have definite information from the WHI that we have an overall protective effect on all sides of the skeleton by administering HRT. So that's good. The gynecologists are still in the prevention using the hormones. What about the bisphosphonates? As mentioned, I think we should be a bit cautious because there are information that long-term treatment may have a negative effect on bones and also on the jaw, inducing osteonecrosis. So what is the current situation? Well, if we look at the pharmacological possibilities of treatment or prevention of postmenopausal osteoporosis, hormone therapy has still its place. And as John alluded to, we can see from the recent Danish studies that even 10 years of treatment will not increase risk of breast cancer, DVT, and even prevent myocardial infarction. So HT, maybe it has a place, so there may be also a place for the gynecologist. And the SERMs, we do not use them that often, but we can use them for a longer period. There's no concern in relation to myocardial infarction, in fact. DVT, yes. So if we move further on towards the senescence, we have the biphosphonates. But I don't think as gynecologist I feel really assured how to administer the different biphosphonates in an optimal way. And what about PTH? I don't think gynecologists should administer PTH. And when it comes to strontium malonate, I also feel a bit uncertain on how to use it in the optimal way. And not least, the rank ligand treatment, the molecular treatment, which is very efficient, you also need some special knowledge in order to administer to the right patients. So, do gynecologists have a role in the treatment of postmenopausal osteoporosis? Primary prevention, definitely. Secondary, also yes, because we can treat for a longer period according to the most recent data on safety. But for tertiary prevention, I don't think gynecologists should be involved. They can discuss with endocrinologists. They can be part of the management, but I don't think they should have the final responsibility for the treatment. Thank you.
Thank you.